Good afternoon. This is Jason Jones with the Community Technical Assistance Center, and I would like to welcome you to today's webinar, Evidence-Based Treatment for First Episode Psychosis. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining the webinar, you have been placed on mute to avoid any background noises that may distract others from listening to the presentation. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. You will have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the right-hand side of your screen. If it isn't visible, click the dialog bubble on the top right toolbar and it should appear. In order to ensure that we are able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the webinar, and we will address them during the Q&A portion of today's presentation. We are very excited to have with us today Dr. Aruma Bello, Co-Associate Director and Clinical Training Director of OnTrack New York. Once again, thank you for joining us. I will now pass it along to Dr. Bello to get us started. Thanks.
Thank you, and thank you everyone for attending today. I'm really excited to present to all of you, and I look forward to hearing your questions at the ending of the presentation. So let's get started. Today we're going to go through and discuss evidence-based treatments for first episode psychosis. And primarily we're going to focus on what we do with the OnTrack New York initiative at the Center for Practice Innovations. So we're going to start by talking about what is psychosis, what do we look for when we're thinking about psychosis, giving some practical tips around how do we explain psychosis to youth and families, how do we talk about it. Then I'm going to provide you with some background and context for the current services that we have in place in New York State, specifically around coordinated specialty care at OnTrack New York. And then some tips for working with individuals with first episode psychosis. And then I'll end with some resources that you all can utilize, go to those web pages, or utilize in your work. So what is psychosis? When we're talking about psychosis, we're really talking about an umbrella term for a lot of different psychiatric conditions. And in essence, it refers to when somebody loses contact with reality. It's an experience that a lot of people have. 3 out of 100 people experience psychosis at some time in their lives. Most people recover. And then FEP refers to a first episode of psychosis, so the first time that somebody experiences intense symptoms of psychosis. So what are the symptoms that we're talking about? First are delusions. And these are guided by the DSM-5. So when we think about delusions, we're really referring to false personal beliefs not subject to reason or contradictory evidence, not explained by culture or religion. So these are persistent. There is a lot of conviction associated with the belief. Then we have hallucinations, which are all types of sensory experiences without external stimuli. And there's, once again, a compelling sense of their reality. And then we have disordered speech and behavior. So when individuals are behaving in a way that doesn't fully make sense, that isn't very linear, that might be another indicator. In the DSM-5, in order to obtain a diagnosis of schizophrenia, you need 2 or more of the symptoms that we talked about, or it could be negative symptoms as well, for at least a month. In addition to that, you need functioning decline and 6 months worth of the symptoms being present. And I highlight this because for first episode psychosis treatment, the folks that we are targeting, the folks that we are treating, aren't necessarily meeting that schizophrenia diagnosis. They might have had symptoms for less amount of time. They might have had symptoms that are impacting their functioning, but at different levels. So the idea is not just folks with schizophrenia, but rather a broader term with people experiencing their first sort of episode. But we're drawing from the schizophrenia literature because a lot of, especially in New York State, the services that we provide within a lot of our models are for non-affective psychosis, or for people who typically go on to develop schizophrenia. So we know that it occurs at an annual incidence rate worldwide at 15 per 100,000, although we're not very sure about the validity of that. There's some research to indicate it might actually be a lot higher. And the ratio of male to female is 1.4 or to 1.6, so definitely more males than females. It develops early, between the ages of 16 and 25, with men having it earlier or developing it earlier than women. And it's an illness with a lot of burden for the system. People get hospitalized. There's frequent hospitalizations. There's people get on long-term disability or SSDI benefits, and it's very costly with regards to being not the highest prevalence of mental illness out there, and yet there's a high disease burden. In youth, because these programs do run the gamut of people under 18, people above 18. So in youth compared to adults, child-onset schizophrenia is actually rare, and the incidence is not well established. But 20% of adults with a diagnosis report onset before age 18. So there's definitely an issue around diagnosing and identifying this, which is less precise when people are younger. So traditionally, we think of the progression of psychosis as a premorbid period. Here you see in the red a premorbid period where people do pretty well. Normal functioning, people do well in school, they're kind of attuned to their tasks, socially they're fine. And then in late adolescence, early 20s, there's the onset, so that's the green and purple. So there's a period of prodrome for some folks where there is some decline in functioning, somewhat unclear what's happening. It's hard to be precise at this point. There might not be frank psychosis, although there might be some oddities or decrease in functioning or social isolation, things like that. And then what we know traditionally is that folks then develop this pattern of peaks and valleys, which is this purple part where they're having episodes. And during that time, it's sort of as their life is quote-unquote deteriorating, right? They're not attaining school. They're not attaining work goals. They are becoming isolated from society. A lot of times are just focusing on their treatment. And then there is, later in life, a period of just chronic disability. What we like to do is we like to switch this graph from this very negative sort of dire picture to thinking that with early intervention, we might change this. And what we actually encounter in the beginnings of this green sort of period is a margin of prevention. And the research indicates, and I'll talk a little bit more about this, that if we intervene early, we can actually make a difference. So in your work, you might encounter individuals and their families, because we're talking with about a younger population. Their families tend to be very much involved in their lives, very much involved in what's going on, and supportive in some ways. So how do we talk about or explain psychosis? Because psychosis can be quite scary when people hear about it. And by virtue of the definition of first episode psychosis, it isn't something that people may have come across before. And if they have other family members who've experienced this diagnosis of schizophrenia, the messages that they might have heard might not be the same ones that we would want to deliver at this point. So things have shifted when it comes to talking to people about psychosis and what we know. So the first piece is really being clear to help people understand what is psychosis or give them information, and information that's rid of jargon. So it involves telling the difference between what's real and what is not. So in some ways, it's like this very practical way of describing it. It can affect the way the person thinks, feels, and acts. Symptoms of psychosis are different from person to person, may be different over time. Sometimes people think that this snapshot of what's going on right now is what it will always be or all it could be. And as we know as providers, these things shift, and they can take on different forms. So we want to convey some of that uncertainty and convey some of that shift to our individuals and our families. And then the first episode typically occurs in the late teens or early 20s. Symptoms may start suddenly, or for others, they may develop gradually. The other point to really drive home is that folks are not alone. Normalizing the experience of psychosis, that it happens across race, across ethnicity, across socioeconomic status, and that there is support and there are treatments out there. So really conveying this message of hope, conveying this message that the illness has sort of programs that could help, that have evidence-based practices that could be delivered, and where the experience could be discussed in more depth and not only provide support to the young person, but also to the family who is undergoing this process. So how do we talk about hallucinations? So you might describe it, right? You might describe it in very concrete terms. Hallucinations cause people to hear, see, taste, or feel things that aren't there. They seem very real for the person. They often have difficulty believing that they're not real. So sometimes it's talking to families about, just because you explain it or you use logic, that might not get, your point across. You're not going to convince the person otherwise, because there's an intrinsic sort of feeling connected to this idea of what's happening. And as such, kind of arguing with young people about what they're experiencing or trying to rationalize them out of thinking about hallucinations in the way that we would with somebody that doesn't have psychosis might not work as well. So you want to use simple language and sort of explain the range. Similarly with delusions, you want to explain that they're beliefs that people hold despite evidence that those beliefs are not true or accurate. So believing that one is being watched or followed is very typical. Believing that someone is controlling one's thoughts, that others want to harm you, that things in the environment have a special meaning for you. And once again, helping people and their families understand that this symptom in and of itself means that, giving evidence against that delusion is not going to just convince the person otherwise. So there has to be other ways of managing. Confused thinking, so actually recognizing and having people recognize that this is a symptom, that people's thoughts and the expression of those thoughts don't really connect in a way that makes sense, either because they're jumbled together, because they're not clear, because they're not linear, because they're too fast, because they're too slow, because there's voids in thinking, etc. This is something that people are not used to, so they might not even know how to think about it or recognize it. And then changes in behavior, which is typically what we hear more. The young person spending more time alone. These are some of the negative symptoms, right? Having less interest in socializing with friends or family, having less interest in going to work, and really understanding and helping the families understand that this is part of the symptomatology. This is not just the person being lazy or the person being oppositional or any of those other sort of explanations, but rather these are things that are true for young people across the board when they have a first episode of psychosis. Not taking care of themselves as well as they used to, behaving in a way that doesn't fit in with the situation, laughing inappropriately for no apparent reason, for example. So the other piece that we always get questions on is, where does this come from? What do we know about the causes of this, and how do we understand what could have caused this? Why is my family member, why is my loved one experiencing this? And this is tricky, because as with many psychiatric illnesses, we don't have one cause, and it's not quite linear for everyone. So the idea is that you help people think through the range of things that could be contributing to this, right? So there's some biological underpinnings. Some people have biology or hereditary things that cause them to have issues with neurotransmitters or have issues with their brain chemistry, or just it runs in families. So just giving people this level of information in a way that is easily accessible could be helpful. But then it's also giving the message that it's not just biology. There's a lot of other factors which we typically put under the umbrella of stress, right? And stress could be anything. Stress could be a shift, going to college and all of a sudden getting involved with your friends, who are using drugs, or stress could be getting overloaded because your life situation changed. Stress could be trauma. There's a lot of different ways that stress manifests itself and affects people differently. But the combination of the biology and the stress a lot of times together might lead to the cause of psychosis. But it's hard sometimes to explain that there isn't a blood test. There isn't something that definitively tells us what's going on. And we know that for young people particularly, there's a ton of uncertainty around the diagnostic piece because we know that things shift, things change. Not everybody develops schizophrenia when they have psychosis. Some people get better and it never happens again. Some people have bipolar disorder. Some people have other diagnoses. So it's really a period of time developmentally for individuals where it's hard to pin down. And living with that uncertainty and knowing how to manage expectations around that could be really helpful in working with families and with young people as well. Okay, so let's switch gears now and talk about setting the stage, the background and context for services. Why do we promote what we promote? So when we think about our system of mental health care, it's a jagged and convoluted system. Normally, when people experience a first episode of psychosis, they aren't necessarily immediately getting referred to specialized services, specialized early intervention services at that. A lot of times, there's things that happen even before people seek help around stigma, lack of knowledge or distrust, or the onset is so slow that people are thinking, this is just because I'm stressed out, I don't really need help, I want to figure it out on my own. And then when they do seek help, it's not a linear path. A lot of times, people don't have access to the right type of care, or the general practitioners or physical health providers might not be aware of how to refer accordingly, or people can't afford certain types of care. There's just general inefficiencies. And a lot of times what we see is that our young people end up either in the police custody because they did something, sometimes due to their psychosis, sometimes something on the side. But the reality is that they get identified by the police, they end up in emergency rooms, they end up in inpatient units, and usually then they get referred to outpatient mental health clinics. And it becomes a revolving door because it becomes very difficult to engage these folks. They're young. This is their first experience. The hospitalization and the interaction with the police can be quite traumatic for some people. And then once they engage in outpatient services, they a lot of times don't identify with having an issue, don't identify with needing these services, and then they kind of just drop out of care and end up back in the emergency room and back in outpatient care. And it becomes this cycle. Or there's people that do end up connecting to outpatient care, but their whole life revolves around getting care rather than pursuing their goals. So there becomes a long-term dependence on mental health care systems, which we also don't think is ideal. So there's two scientific findings that are important when we were thinking of first episode psychosis. One is the longer the duration of untreated psychosis, so the period of time between when a person first starts experiencing symptoms to when they actually get connected to services, the longer that takes, the poorer people tend to do short-term and long-term. Similarly, we found that there is evidence that coordinated specialty care, so getting people early, but getting people into the specialized service, and I'll describe what coordinated specialty care entails, is associated with better outcomes than treatment as usual. So what are the benefits? There's been a lot of studies done on this, and this looks at 4 meta-analysis of randomized controlled trials, and they all support early treatment models. What we see is that these types of early intervention specialized services, these team-based approaches, improve rates of hospitalization, meaning people don't go back to the hospital as much, their symptoms get better, there's less relapse. And the specific elements that a lot of these models have delivered are low-dose antipsychotic medication, CBT therapy, CBT for psychosis therapy, family psychoeducation and support, and educational and vocational rehabilitation. And this is like internationally. So in the U.S., given all of this research and given the status of understanding that these specialized early intervention programs work, the National Institute of Health and of Mental Health funded the RAISE projects to determine if this applied also here in the U.S. And it's called the Recovery After an Initial Schizophrenia Episode, and it was hoped to be an initiative to fundamentally alter the trajectory and prognosis of schizophrenia by providing this coordinated and aggressive treatment. And there's a lot written about this, but I'm just going to give you a quick snapshot, right? One was a randomized controlled trial that compared the effectiveness of the specific team-based early intervention approach compared to treatment as usual. And they got 34 clinics, not academic centers, just standard clinics throughout the U.S. 17 received training and delivered this, what we now call coordinated specialty care, and 17 provided treatment as usual. And then in addition to that, there was an implementation study that was really focused on identifying what were some good strategies for generating referrals, for finding people with first episode, for training and supervising staff, and financing models to support this treatment. So what did we find? In the randomized controlled trial, we found that participants stayed longer in treatment, which, as I mentioned earlier, traditionally it's been hard to keep these folks in treatment. They had fewer psychotic symptoms. They reported higher levels of quality of life, and they were more likely to be in work and school. Similarly, in the RAISE connection, the one that just used like a convenience sample of people, done here in New York and in Maryland, they found that also they had high engagement and retention rates, significant reduction in symptoms, improvement in social and occupational functioning, and rates of engagement in competitive work or school were doubled. And I highlight this because our coordinated specialty care program here in New York State is based on the RAISE Connection Project. The RAISE Connection Project was done out of the Center for Practice Innovations, the Psychiatric Institute here, and it became On Track New York, and that's what we're implementing now. So in the big picture, what these programs are hoping to do and what they're really targeting is to reduce the amount of time that it takes people to get to services, so identifying people early, but then also to provide early intervention services. So it's twofold, right? It's getting people into the care, but then getting people into the right care so that they receive things that we think are going to change their outcomes based on the literature. So this is the pathway. There's onset of symptoms, people seek help, and ideally, once people are in that help-seeking stage, instead of going to the police or going to inpatient or whatever, they would actually get referred to mental health services. And then from there, they would get referred to early intervention services, which are our teams for On Track New York. But I would say that the ideal would be to even shorten this, and that people are familiar enough with early intervention coordinated specialty care program so that becomes sort of a frontline referral. So what do we mean by coordinated specialty care? It's a suite of evidence-based practices that delivers case management, supported education and employment, psychotherapy based on cognitive behavioral therapy for psychosis, family education and support, evidence-based psychopharmacology, and primary care coordination. And then the way that it's done is also, specialized. So it's a team-based approach. They have specialized training in first episode psychosis and the guidelines for treating first episode psychosis. They have the opportunities and the capabilities to do community outreach and be flexible and see people in the community if they need to. They have and are encouraged to not only engage participants but also their family members and to work closely with families. They're able to do mobile outreach and crisis intervention as needed, and then using a person-centered approach that focuses on shared decision-making. So this is how we promote our programs here in New York State. And as you can see from what's on this slide, there isn't any terminology around psychosis or recovery or any of these terms that have been connected to mental health, but rather it's a more direct message that it's for young people who have experienced unusual thoughts and behaviors, and that we really focus on their goals for school, work, and relationships. So really tying it to what's important to that individual. And On Track New York, so it's the type of coordinated specialty care that we have here. The idea is that they provide hope to participants and families so that people with psychosis can achieve their goals in life. And instead of working with one person, it's a collaborative team approach. There isn't any piece of the model that's mandatory, so people sort of can come in and out of the pieces of the model that they want to engage with, in addition to their family members having access to the entire team. And then we have a team leader that really focuses on making sure that there's teamness, that everybody's working together, and that all of the philosophy and the clinical practices of the model are being done correctly. So really being guided by people's preferences. So what do we offer? What do we give people? There's a comprehensive assessment that goes into determining if somebody is eligible. So for providers, this could be quite helpful in terms of making referrals to On Track to help, whether it's connecting them to the service or having a more extensive evaluation that could help, the referral source identify other forms of treatment that might be more suitable. And then the idea is that there's a whole team of people that are able to provide the specific evidence-based practices that have identified to work with folks with schizophrenia or with young people with early psychosis. And then to be able to help their families and really help teach family members how to assist a young person in their recovery. The other piece that's really important of our model is the supported employment and education specialist, which sole purpose on the team is to help people identify and reach school and work goals. So it's this person that has the bandwidth to help the young person navigate the employment world and the education world and get support and help them get established. And then also helping them with strategies for building healthy relationships, coping, if they have any comorbidities, whether it's drug and alcohol problems or depression or anxiety, we're also able to do that. And then the model is time limited. So it's an average of 2 years. Some people stay a little longer, some people less, but the idea is that, this sets them up to start doing better, and then they might benefit from outpatient services that are less intense. So this is what our model looks like. It's a suite of evidence-based practices, as I mentioned, with all of the pieces that are the services that get delivered, but with a strong emphasis on outreach and engagement, a strong emphasis on peer support throughout the model, and all under the umbrella of shared decision-making, because everybody works together to decide what are the right treatments or evidence-based practices that the young person should engage with, and all of that with the idea of helping the person attain goals and recovery. So our eligibility criteria, I'll just go through this quickly. 16 to 30, it's primary non-affective psychotic disorder. People, in order to be in our teams or receive services from our teams, have to have psychosis for more than a week but less than 2 years, and they need to be New York residents. However, if they have an intellectual disability or on the autism spectrum, they don't qualify. If they have a primary diagnosis of substance-induced psychosis, mood disorder with psychotic features, or psychosis secondary to a general medical condition, they don't qualify. Or if they have serious or chronic medical illnesses that significantly impair functioning independent of psychosis, they might not be a good fit. And then our teams, just to highlight, they provide services to all individuals that meet our criteria without wait lists and regardless of insurance status. So providers typically might come across folks who have some of the symptomatology, and they might think, oh, this person might benefit from early intervention services. And we have teams throughout the state, so they might make an initial phone call. Otherwise, sometimes family members or other professionals or the individual themselves generate a referral. Then from there, the team evaluates and determines if the person meets eligibility criteria. And if they do, then they're offered enrollment. And it's really then up to the person if they want to do this or if they don't want to do this. Okay. And then this gives you an idea of where our programs are located. As you can see, it's throughout the entire state. And then hopefully in areas that are more highly populated. Although I will recognize that we're not servicing every single part of the state at this point. We're still in expansion phase. So now I wanted to give you a case example of an individual that one of our teams worked with to sort of help you get a more concrete picture of how this typically goes and how it all works. So this is the story of Caitlin, and Caitlin is a young person who, for a year and a half, started experiencing psychosis. She was hearing voices, feeling paranoid, and also during that time experienced significant traumatic family events that contributed to exacerbating her symptoms. And although high school had gone well, she was struggling in college and thinking about dropping out when she was hospitalized for a full month because of psychosis. So the inpatient hospital team made a referral to the on-track team. And even yet, it wasn't very easy for Caitlin to want to engage with the team. The team struggled to engage with her for 4 months. They kept trying. They tried a lot of different strategies. Their teams can be quite flexible. So they had the peer specialists meet with her in the community and at her home. They arranged meetings with supported education and employment specialists to see if by helping her identify work and school goals, she might be more willing to work with the team. They worked with her in identifying coping skills. So although she was coming to her appointments, she didn't really feel like she was engaged. The progress was really slow. She was disappointed. Her family was also disappointed. And the treatment team at times in the beginning were quite frustrated. But then, as we know in our program across time, there's different ways in which people engage. And for Caitlin, something shifted. The SEES, a supported education and employment specialist, was actually able to connect her with a local retail employer. And once she got this job and she was hired part-time, it took her confidence. There was a boost in her confidence. And she started talking with the team about maybe returning to college, and then sort of processing what are the ways in which she was scared, what are the pros, the cons. And this really helped the team figure out a way to align with her and align with her goals and support her. So they worked with her for an additional 8 months, and during that time, she started college. She was going full-time. She's earning mostly A's. She's interacting with friends, dating, and forming new friendships at school. She showed up at the end of the semester to the clinic and announced that she had made the dean's list. So Caitlin and the team worked really hard together across the period of 8 months. And as you know, it was hard to engage her, and then once she started actually becoming more involved and more engaged, then the work was able to progress further. So some of the ways in which she worked with the team. So she worked with a primary clinician with therapy and CBT and skills building. She worked with the psychiatrist on trying out different medications until she found one that really kind of felt like it worked for her with not a ton of side effects. She attended groups run by the peer specialist, so she connected with others and the peer specialist around their lived experience. She also would meet with a nurse. Our teams have nurses to talk about wellness. So she would receive an injectable medication from the nurse, but also talk about dating and sexual health. Then Caitlin's family also got psychoeducation. They were able to attend multifamily support groups, and her uncle also was able to join the groups, because our approach to the family is a very broad approach where it's whoever the person finds important and can identify with, then that's who we would involve. So in this case, it was her uncle. And then the team also has the possibility of meeting with the family individually for family consultation and skills building with the family. So eventually, Caitlin and her treatment team, because of the progress that they have made, are now thinking about planning for transition. As I mentioned, our program is a time-limited program, so people don't stay with us forever. At the same time, we try to advocate for a slow transition. The idea is that there should be enough time between when the person is doing better to discharge to try things out and to identify what are the resources and supports that the person is going to need moving forward once they get discharged from the on-track team. So in this case, it was setting up mental health services for her in an outpatient program and identifying how she will continue progress in her life and career goals with attending college and how her family could support her in that. So that's one example of how it could go with one of our on-track teams. Now I'm going to switch gears and focus a little bit more on general tips. So if you have folks in front of you who might have this and you're kind of wondering how to engage with them, for example, a lot of times, as we noted, young people don't necessarily think that they have, psychosis, or furthermore, they don't think that they need treatment. Like, they think they can figure it out on their own. They think that it might be like a one-off. It might be something that is related to stress, or that they use drugs, and that it'll just go away. And the idea of being something coming out of the blue in this way and then associating it with this long-term treatment and this long-term, now I have to engage with providers, isn't the most attractive. So when we think about engaging young people, we start from what do we think is going on for them, and what do they want? So it's sort of like asking questions and exploring how they might find something to be helpful, rather than us telling them what would be helpful. So, for example, what kinds of programs or treatments have they already tried, and what were some of the challenges with this? What do they think about mental health treatment in general? What are some of the pros and cons about it? And what are some of the biases that they may have about it? And then based on that, you describe the services. So, for example, if a young person is coming in and they're saying, like, I don't think there's anything wrong with me. I'm doing fine. I'll get better. This will just go away on its own. I really don't want to take medications. In the hospital, they told me that I had to take medications for the rest of my life, and that's not what I want to do. Then really understanding, I would switch that conversation to, what are some of your goals? What are some of the things you're trying to accomplish? Is this getting in the way? And here are some of the things we can provide. So if your goals are going back to work at school, we have a supported employment and education specialist that can help you with this. If you don't want to take meds, that's not a requirement for our program. We can have discussions around that. So really making sure that we're connecting an exploration with detailed examples. So, going into the weeds, we have somebody with lived experience, and they might connect with you and let you know what they went through, and that would be talking about the peer role. We help young people get jobs in these areas, doing this thing. We've helped young people get, figure out what they want in terms of friendships and relationships and get those goals or pursue those goals. What gets in the way with engagement that we've noticed is when we talk about things mechanically. When we talk about, you're going to go to therapy and you're going to go and get meds and you're going to go and meet somebody for help you with school and work, and without eliciting what the person wants, it can feel sort of devoid of any meaning. Or also asking too many detailed questions. A lot of times with our young people, we're so focused in trying to understand what's happening for them in terms of their symptoms that it can be quite off-putting, because they might not want to talk about all of those things from the beginning. They might be more interested in actually connecting with you around their goals and their life outside of their symptoms. So during these early stages, it's important to be mindful that the young person's experience is unique, and that they have their own understanding of what's happening, and meeting them where they're at or adopting their language into the conversation can actually be pretty powerful. So for a young person who thinks, I wouldn't label this psychosis, I think that I am struggling with my family, for example, and that's why I'm feeling this way, then adopting that language rather than persisting on the language of the diagnoses could help with engagement. And it's also important to do this with families. It takes a while for people to develop some meaning around their experiences and maybe come to terms with a diagnosis or not come to terms with it. So we don't want to do this or pressure them into this, because this labeling of the experience could lead to somebody being put off, somebody feeling like they're getting stigmatized or having some internal stigmatization, and then just general disengagement. It's also important to understand the cultural context of things and incorporate that as much as possible. And that might mean asking the young person and the family, how does your wider community understand what's going on with you? If there's any specific religious beliefs, understanding what those are. If they have certain views on mental health treatment, for some communities it's quite embarrassing or stigmatizing to connect with mental health services. They might not want to disclose certain things. They might not want to share, and therefore they might be quite isolated. So you want to incorporate an understanding of all of that, even from like day one that you're meeting people and talking to people, because that helps sort of set that stance where it's positive, it's hopeful, and therefore you can identify what are the true ways in which you can connect with people that are going to keep them coming back. Then the other piece is when the person says, which happens very frequently, when the person says, I'm not psychotic. You're wrong. I don't have this mental illness. So that's where you ask them what might be the problem. And not only that, but what do they think is helpful? What would they find helpful? Because that gives you a window for engagement. Then you can tie how the services can help given their understanding of the problem. But you don't want to convince the person that they're psychotic, but find some common ground. So can we all agree that you're struggling with school? Can we all agree that you are isolated and you would want to engage more with people and you're not sure how to? Things like that. And then that becomes your diving point for understanding the person and therefore connecting what teams can offer or what you can offer. Then there's the idea of recovery and this optimism and hope that I was talking about. Traditionally, people have gotten this very kind of depressing message that they have this illness that's chronic, that's lifelong, that they have to take meds forever, that is just kind of gloom and doom. And the reality is that providers, the clinicians, we play a vital role in detecting first episode psychosis. But ideally, if we're connecting them and delivering the right services, we're also playing a vital role for people believing that there is life notwithstanding psychosis, that there's hope, that people with all kinds of symptomatology and all kinds of presentations have gone on to do really important, cool things and have been able to accomplish their goals. And I think that that's not the message most people are getting. So even starting there would shift things. And then sort of providing some of that background that I shared with you earlier, right? Like there's research to indicate that these types of specialized services improve clinical and functional outcomes because they focus on the individual's goals to guide treatment decisions, explaining to people how it's person-centered and how their preferences are taken into account and how they're expected to be an active participant of shared decision-making. All of that sort of conveys a different message when working with young people and can really shift how they think about what's going on with them and the kind of help that they want to engage with. You also want to encourage family involvement. We know that most of our young people are still living at home, and their family is providing a ton for them, not only financially, but just general support. So the more that we can help that family, the more that we're helping the young person because they're not separate things. And a lot of times, in the adult world, in the adult mental health world, these things have been siloed. So it's important to integrate. And then help the individual develop skills to manage the symptoms and prevent relapse. So it becomes a very practical approach, a very practical way of kind of working with people. So that's where you talk about the collaboration. It affects young people who are living at home. The family a lot of times is the one that notices the changes. They don't understand what's happening, so they need a framework of how to help, of how to be helpful, of how to minimize family discord. And through programs like On Track New York or coordinated specialty care programs, there's a bandwidth to do that. So now I'm quickly in the next minute or so going to talk about our resources, which could be helpful for any provider out there to become familiar with. Because there's the idea that you could refer to On Track New York programs, but there's the idea of some of this could be useful in the work that you're doing. So we have our ontracknewyork.org website, and in this website you will find the manuals that our clinicians and our teams use, guides for delivering culturally competent first episode psychosis care, guides for treating cognition, and then there's a ton of links. There's links to recovery videos with people who are sharing their recovery stories around first episode psychosis, which can be quite powerful for young people to see. We have these videos that we filmed from participants or about participants that had received services, and they're pretty short, but they sort of help normalize and give young people and families an idea about what it's been like and what people experience and how our model has helped them. So that's another thing. Other resources that are out there, here in the city for young people with prodrome, for example, there are definitely clinics. So Mount Sinai has a clinic for young people 12 to 30, so they go down in age. There's the COPE Center out of Columbia, which is for prodrome, so people who don't have frank psychosis could get treatment there. There's other programs that are early intervention that are not on track. There's one at Zucker Hillside at Long Island Jewish, and there's one at Lenox Hill, and their criteria is a little different, but it's still for first episode. And then there's in the city, there's New York City START, which provides it's like a 3-month case management service to transition people from the hospital to outpatient care. So we are at 12:45. We have 15 minutes for Q&A. I will stop here so that we can have a little bit of discussion in case there's things you want me to talk about more or clarify.
Awesome. Thank you so much for that great presentation. And we could jump right into questions. Many of them came in. So one of them is, how do you work with family support systems with certain cultural or religious beliefs that youth may have demons inside, or really just talking about cultural and religious beliefs as a whole?
Yeah, that's a really good one, and that's why I alluded in the resources to that guide of culturally competent care for people with FAP, because our teams see this all the time. And the idea is that when people have cultural ideas around what's happening, first, it's really important to ascertain what those are. You want to ask questions. The cultural formulation interview that's in the DSM is a really useful tool for doing this. You're asking people, okay, what do you think is going on? And they might tell you, I think it's demons. I think it's possession. So then you want to try to find some common ground, and you want to incorporate and partner with the community. So if they're thinking it's demons and they have a church that they go to, can you involve the church advisor or the priest or the pastor, whoever they identify, into the treatment to have conversations? And what typically happens is that you're not trying to convince the family that it's not demons. What you're trying to figure out is what is some common ground. Can we do both? Can we do prayer circles and also consider therapy or medication or, the pieces of our model? And usually it's a trial and error process where people might try certain things that may or may not work, or it works part of the way, and similarly for our services. So the idea is that you are involving them, you're hearing them, you're validating for them, you're being respectful of their cultural beliefs, and then you're partnering. You're partnering with them and with whoever they identify as being important. Of course, this also is guided by young people's preferences, right? So this is in the case that the young person also either ascribes to that belief or is okay with that. I think where it becomes more challenging is when the young person doesn't think one thing and doesn't want family involvement, doesn't want involvement of the broader community or the religious community, and then you might develop some kind of negotiation around that in conversations, So you live at home, your mom thinks it's this, you don't think it's that, but how is that getting in the way? Does that mean you're having arguments with your mom? Does that mean that your mom wants you to do different things and it's creating a lot of family conflict? So let's talk about it in that way. How might your family be involved while we respect their beliefs but not necessarily, include everything that you don't agree with? So it's tricky, but there's a lot of different ways. At the end of the day, it's really understanding where people are coming from and trying to find common ground, I would say.
Great, thank you. Another question that came up was differences in onset in terms of gender. So do men typically experience first onset before women? And are there different engagement practices depending on the gender of the client?
It's an interesting question. Yes, we do see more men than women. With regards to the engagement, we haven't specified them based on gender in coordinated specialty care, although I think that that's an area that still needs to be explored. I don't think we're there yet to be that precise or specific, because what we say is we individualize it and we tailor it to what's important to that person. And in the assessment or the evaluation process, you're trying to elicit irrespective of gender, like who is this person and what do they want and how can I help them with what they're seeking. So kind of that's how I would answer this. But there isn't anything to indicate specifically for males do this, for females do this.
Great, thank you. Another question that came in was, for patients who experience their first episode, what should I explain to the patient and family about what could happen in the future? So thinking of second episodes or particularly about recovery.
Yeah. I mean, I would emphasize hope. I would say kind of the message is normalizing the psychosis, normalizing the uncertainty when they're young, that we can't be 100% sure of what's the trajectory because we just don't know. That we recommend, you can definitely share your recommendations around evidence-based treatments, and that we know that, medication helps, and we know that for some people, like therapy and or coordinated specialty care works. But it's really also conveying this very direct message that with treatment, people can go on to live really great lives. There isn't a need for, long-term disability or this idea that your life is over. So it's really conveying some of that hope. And that's where some of these videos could be really handy, because it's instead of you as a provider trying to convey this message, like if you can play a 5-minute video and they can see a young person thriving, even though they had pretty severe symptomatology, it sort of conveys that message of hope without having it come from you. This is coming from another person who's experienced this. But I would really underscore the idea that there is a rich life to be had, and that things will get better and can get better, that it takes time, and that there are treatments available. And then if you're doing more intense work with someone, right, so if you're not referring them to another service and it's you the one that's providing some of the psychotherapy or the psychopharm treatment or whatever your role is, then I would really draw from the psychoeducation materials about how to talk about psychosis and how to think about it for families and for young people. And you can find some of that stuff in our manuals, where you're really educating people around the different relevant topics, the symptoms, how they present, what are some good strategies, how do you think about medications, how do you talk about side effects, all of those things, so that it becomes this very open conversation on how to think about this, and you're giving people really good information.
Great. Another question that we have is, what is the best way to assist or treat children if they are having a first episode of psychosis while they're actively engaging in therapy?
So I guess it depends on the age of the child. If the child is experiencing like frank psychosis for more than a week, or now it's like a primary psychotic disorder, then I would say that the psychotic disorder should get treatment. So that might be, depending on the age of a child, sending him to specialized services for this. If not, then there's definitely like CBT for psychosis approaches that the provider could start implementing, but I would recommend that they send them to somebody who specializes in this if that specific provider doesn't. If the specific provider has experience with this, then I would say switch your therapeutic approach to a more CBT for psychosis type of approach to target those symptoms.
Thank you. Also, are there questionnaires that could be administered to assess a patient's symptoms? So specifically, are there any available treatment guidelines clinicians can use to provide psychotherapy as well?
Yeah, I mean, once again, the evidence shows that it's the coordinated specialty care model that is effective, which is this multidisciplinary, collaborative, integrated approach that is what helps. So I do want to underscore that. At the same time, I know that not everybody will have access or not everybody will want it, and you might still find yourself doing psychotherapy with someone. And then that's where, once again, I would say just go back to the guidelines for CBT for psychosis. There's manuals out there that provide you, but really having some experience and some supervision on how to do this becomes paramount. So that because CBT is the most evidence-based approach right now. And then in terms of questionnaires, the way that there's assessments out there that can be done. There's definitely research type of assessments that people do that are a little bit cumbersome, time-consuming, and require a ton of training. So it just kind of depends. With our teams, what we do is a timeline assessment where we are guided by the positive and negative symptom scale, questions for assessing positive and negative symptoms of psychosis, but instead of administering the whole entire scale, we ask in a timeline when things happened in time, when they got worse, and then at the symptom level, like what did it look like, did it impact your functioning, and so on and so forth, to figure out if people meet eligibility criteria. So there's a range. There's some people that have, you could use a SCID, which is the structured clinical interview for diagnosing. You could use, there's different instruments. The problem is that a lot of the instruments are burdensome and require training.
Got it. Thank you. Another question that came in was someone asked if you could really differentiate between an initial episode triggered by substance use versus substance-induced psychosis, and how can you tell the difference within a client?
I'm sorry, whether it's substance-induced or not, or whether it's...
Well, I think what they're trying to ask is, could the first episode be triggered by substance use?
Right, which is substance-induced psychosis. Mm-hmm.
Right.
Yeah. So once again, with the timeline assessment, a lot of times if you can determine that the person before the psychosis was using substances and outside of the substance use they're not really psychotic, then it's typically substance-induced psychosis. Similarly, sometimes if the person is hospitalized, for example, and then they clear, the symptoms go away, then you can ascertain that it's substance-induced. I think where it gets, and if the onset of the psychosis is acute, right? Because for a lot of people, we see a progressive onset, not something that switches from one day to the next. That being said, it becomes really important to be very familiar with different substances and which ones are associated with psychotic-like symptoms and which aren't. That could help you differentiate if this is substance-induced or not. The other piece is really ascertaining the frequency of the substance use and the intensity of the substance use and how is that in relation to the psychosis. Is it when they use more? The complicating factor, I would say, is that there's some substances, right? So if we're thinking about synthetic marijuana, where the person will develop psychosis and then they stay psychotic for a long time, even after they've abstained from using. There it becomes trickier. But a lot of times you can pinpoint that it started after they started using the synthetic marijuana. So that would kind of guide you in that direction. So it depends. It really just depends on the person's history. So having a good assessment of what their use is like, when, how intense, and how does that line up with the symptoms of psychosis. And when in doubt, I would say if you have somebody who you're trying to assess and it's a little unclear, then getting a consultation from a substance use expert is sometimes helpful because they know more readily like what drugs cause psychosis or cause psychotic-like symptoms and can help guide your thinking. As I mentioned earlier in the webinar, though, there is a period of uncertainty for these young people, so we do the best that we can. And sometimes, honestly, it's not because we're not doing the right assessments, but people don't disclose. And this happens in our teams. People present in a certain way. They're not really saying that they use a ton of drugs. They get accepted into the program, and then you come and you find out 6 months down the line that, in actuality, they're heavy substance users, have been for a really long time, and you don't know if this is really substance-induced or not. There's definitely situations where it just stays unclear. And in those cases, if you're part of the team would keep you and continue treating you. They wouldn't sort of transition you out. But that being said, for some people, it's really hard to know.
Great, thank you. And I believe that we are all out of time for questions. I do want to thank you, Dr. Bello, and thank everyone for attending today's webinar. The slides will be up on the CTAC website within 2 to 3 business days. And I also want to say we invite you to join us for our upcoming events, which can be found on the CTAC website. If you have any other questions, please contact us at ctac.info@nyu.edu. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. On behalf of CTAC and our presenter, thank you for joining us today, and have a great rest of your day. Dr. Bello, again, thank you so much for your presentation. It was much appreciated.
Thank you for the opportunity. Take care.